good morning to all of you, as we are going to have discussion on the cardiovascular manifestation related to COVID case. Why it is important? Because we know after the respiratory illness, after the respiratory cause, it is the cardiovascular is the second most important cause of which causes the mortality. So I'm going to start sharing my screen. I think it's a little lengthy lecture, but I will try to summarize everything in a timely fashion so that we can have some discussion about this COVID management, cardiovascular manifestation in COVID-19. So as Dr. Mishra has rightly pointed out that COVID cases has some respite. We can see that there are cases a little bit coming down, but we can see that there is almost more than 35 millions have affected with this have died because of the COVID-19 worldwide, and we have almost 1 million deaths because of the COVID. And in UP we have almost in the number 4 position because of the COVID. So my plan of discussion will be something like that. Introduction, I will talk briefly about the pathophysiology, then manifestation, then investigation. Investigation related to cardiac illness, the cardiac investigation, how we are going to utilize in the COVID era, and then something about the management and some brief take-home messages. As we know that the COVID-19 is a novel coronavirus, it affects the basically the lung, but also bites the heart. And we already know that the major it's a pandemic which is took shape in the March 2020, and it is rapidly growing. So we know that basically it causes viral pneumonia, but also has a major implication in the cardiovascular system. But we also know that the patient of cardiovascular risk factor, patient who are having a cardiovascular risk factor, for example, patient of male sex, advanced age, diabetes, obesity, hypertension, and as well as the patient who are having established cardiovascular or cerebrovascular disease, they are at higher risk of having mortality or increased morbidity because of this COVID-19 infections. So for a cardiologist or a practicing physician, why it is important to know about the cardiovascular manifestation about the COVID, because we know that this COVID-19 virus is associated with the cardiovascular injury and mortality, and then we know that patients of pre-existing cardiovascular disease are very vulnerable for adverse outcomes because they have higher mortality and morbidity. And most importantly, the physician or the cardiologist will be involved in the care of the COVID-19. So we must know about what are the manifestation of the COVID-19 as a cardiovascular manifestation and how we are going to utilize our services in the better way. Important to note that after this pandemic, we are going to have increased number of cardiovascular cases because we are not able to see them. We are not able to give advice in this COVID era because of the restriction in the number of the patient in OPD, and then there is a travel restriction, and then there was because of lockdown. So we are going to have increased number of cases of cardiovascular diseases after this pandemic settles down or ends. Little about pathophysiology, where we know that the SARS-CoV-19 virus enters into the cells using the ACE2 enzymes, and you know that the ACE2 is expressed in the lungs, heart, and vessels. So that's why these three are majorly involved. And the CVD involvement in COVID-19 maybe because of the primary phenomenon, because the primary toxicity of the virus of the lung, heart, or the blood vessels, or it could be secondary to the acute lung injury. Because of the acute lung injury, it can cause hypoxia and as well as the right ventricular load. Another important mechanism of this toxicity is the cytokine release is strong. We'll discuss a little bit more about it. And then another important aspect of it is that the immune system activation may result into the plaque stability. There will be freshening of the plaque, and that may result into the presentation as an acute coronary syndrome or type 1 myocardial infarction. In this cartoon diagram depicts a brief about the pathophysiology. You can see that the number is the direct cytotoxicity of the virus into the myocardium or into the heart vessel. And then there is a dysregulation of the RAS system, which you know that the RAS system is involved into the vasoconstriction, and then there is a involvement. It causes the disruption or change into the thrombogenicity. Apart from that, there is involvement of the endothelium. Endothelium involvement, which leads to the increased thrombogenicity, and then there is a immune response is also changed a lot because of the defective interferon system. Then the T cell have been depleted. All these leads to the increased toxicity, increased effects on the cardiovascular system. This is a famous diagram you have seen several times, published in the Journal of Heart-Lung Transplantation. This is a beautiful diagram which depicts that how the disease evolve and how the response evolve. You can see that initially there is a viral response phase where there is a viremia and the illness is limited. The clinical manifestation is some upper respiratory tract infection, something like that, and you don't have much change into the investigation. And then there is a stage 2 start when the pulmonary phases start, the pulmonary involvement, which occurs almost 2 to 3 weeks after the initial phase. And then the patient start having shortness of breath, and then SpO2 starts dropping down, and there is increase in the marker levels, and blood procalcitonin remains normal. And third is the most important phase, that is the hyper-inflammatory phase or cytokine storm phase, where the inflammatory response is tremendous, and which causes damage to the patient, and to all the organ system. Patient presents with the ARDS, or he can present with the shock, and then you have all the inflammatory markers, importantly, which we use to measure the CRP, interleukin, and that ferritin, and all the other markers of D-dimer and the FDP products are increased. So you must remember that the majority of the patient who are presenting to us are in this phase with the cardiovascular manifestation. So hyperinflammatory state, as we know that it is mediated, it is also known as a cytokine release syndrome, and it is mediated by the T cell, and there is elevated cytokines, and we know that which we use to measure the elevated CRP and high serum ferritin level. LFBNP can also be increased, and IL-6, IL-2 are increased, but they are very difficult to measure because these are very labile molecule. Acute cardiac injury and myocarditis in COVID, because virus infection directly, it is regulated. There is upregulation of the ACE2 enzymes in the heart and the coronary vessels, and hypoxia per se causes damage to the myocardium. And then immune response, immune mechanisms, because of the cytokine release syndrome, all these causes damage to the myocardium, and that there is a cardiac injury and myocarditis can be there. So this is a cartoon diagram which depicts a brief about how the myocardial injury occurs. You can see there is a hypotension because of the cytokine release syndrome, whatever is the form. So there will be decreased supply, there will be increased metabolic demand because of the infection, because of the tachycardia, and then there is associated hypoxia because of the lung involvement by the COVID infection. And then if the patient is having pre-existing coronary artery disease, all these lead to the decrease in the supply and demand mismatch. So it can cause myocardial injury. If it present with the myocardial infarction, it is known as the type 2 myocardial infarction. Similarly, in the patient may present with the direct myocardial toxicity, or there is important aspect of the microcirculation thrombosis, and the cytokine release syndrome, all these can cause myocardial dysfunction, and patient in the extreme form of the myocardial the stress cardiomyopathy, this Takotsubo cardiomyopathy. So cardiovascular manifestation, as we know that the cardiovascular manifestation, the common, the SARS, the classically SARS has a manifestation as a hypotension, myocarditis, arrhythmia, etc. And COVID-19 is having very similar to that SARS infection. It present with the myocarditis or heart failure. It can present with the manifestation of the coronary artery disease, such as acute coronary syndrome, or patient may present with the cerebrovascular disease because of the thrombosis. Patient may present with the arrhythmia, or there could be a thromboembolic phenomena in form of the pulmonary embolism or deep vein thrombosis. And important to note that patient, apart from the acute complication, patient likely to have a long-term complication because this COVID-19 causes hypercoagulability. There is a systemic inflammatory activity. There is a hyperlipidemia, and the severe cardiovascular system abnormality, glucose metabolism abnormality, and importantly, patient now coming with the pulmonary fibrosis, and with these pulmonary fibrosis, there would be increased load on the right ventricle, and patient may present with a copulmonale or something like that sequelae. So now, manifestation could be because of COVID, maybe because of the patient may present with cardiac events per se and might be having COVID infection, or patient may be, the COVID patient may be having cardiac injury that could present as a cardiac events, or patient of COVID may have a symptoms very similar to the cardiac illness, such as the dyspnea or the shock, which could be the presentation. So there are three major types of presentation. Patient per se having acute coronary syndrome or non-ST elevation, my patient cardiac presentation but having associated COVID infection. Another manifestation is that COVID infection causes myocardial injury or cardiac injury, which is presenting as a case of heart failure or sepsis, or heart failure as a shock. A patient may present with a symptom which is very similar to the cardiovascular disease. These are the three types of manifestation which we see in day-to-day practice. So major cardiovascular manifestation is raised biomarkers, increased chances of acute coronary syndrome, heart failure because of myocarditis or cardiogenic syndrome, increased chances of arrhythmia and thromboembolism. So what troponin is basically an important biomarker for the cardiologist as well as the general physician, and importantly, it was found to be raised in 5 to 25%. In some series, it was found to be raised in 40% of the patients. And it is known the patient who are having high level of cardiac troponin have a higher mortality. And the survivor versus non-survivor, they have very different level of the troponin. Survivor usually have normal range of the troponins. So mild elevation of troponin up to 2 to 3 times should not be taken as a marker for the acute coronary syndrome. And it could be because of the pre-existing cardiac disease, and it doesn't require any routine workup or treatment in these type of patients. Patient having more than 5 times rise in the cardiac troponin should be considered as an important marker for the increased risk for that patient. So it could be because of the shock caused by the cardiac COVID-19 by itself, or it could be because of the severe respiratory failure, because of the tachycardia, because of the systemic hypoxia, because of the myocarditis, and it could be because of the presentation of the stress cardiomyopathy or Takotsubo cardiomyopathy, and it can be because of the COVID-19 has triggered and caused acute ischemia. Usually the cardiac biomarkers increases after 14 days as the duration of illness increases, as the severity of the disease increases, the cardiac biomarkers level also increases. It's a very important slide. You know that acute cardiac injury marked by the raised cardiac troponins are a marker of very poor prognosis. It has been seen that the patient having more than 5 times cardiac troponin levels have almost 50% mortality compared to almost less than 5% mortality. BNP, as we know that it's a molecule which is we use as a marker for the hemodynamic stress and heart failure. But importantly, this molecule is not very beneficial in patient with the COVID infection, and it could be because of the associated cardiac illness or not illness. So routine in measurement of BNP is not indicated. It should not be encouraged in the COVID infection. D-dimer is a very important marker, and it should be, I think it should be done routinely, and it should be done daily in a moderate to severe diseases. It might contribute to acute myocardial injury because of the it is a marker of activated coagulation or impaired fibrinolysis, or it's also affect the coronary capillaries. It is a marker of activated coagulation system. So routine measurements of marker of this hemostasis is recommended in form of the routine measurement of FPTT, PT, of FDP or D-dimer of fibrinogen level. And elevation of D-dimer have been associated with the poor outcome. So these markers should be evaluated almost daily or every second day in a patient with moderate to severe disease. So patient may present with the type 1 myocardial infarction because of the activation of the cytokine system, and there is an increased SAMs and DAMs, which can cause fissuring of the plaque, and there is an increased atherosclerosis, and all these can lead to the fissuring or rupture of the plaque, and there is a thrombus formation. Patient may present with the type 1 myocardial infarction. So there is one example. This is patient of COVID pneumonia. When we received this patient in COVID ICU, the patient had already acute myocardial infarction. Another patient who had chest pain in isolation ward, and when shifted to the COVID ICU, he had already ST elevation MI, which had already settled down, but the R wave is still present, but the ST elevation is still persisting, and T inversion is there. So these are the typical presentation of the COVID patient presented with the acute coronary syndrome. These were the ST elevation MI. Another example, another type of myocardial infarction which is common in the COVID patient is type 2 myocardial infarction because of the tachycardia, because of the fever. There is an increased demand, and then there is a patient is having hypoxia. There is a microvascular dysfunction because of the increased thrombosis rate. So there is a demand that supply mismatch, and there is a myocardial ischemia. Then these patients may present as a patient of myocardial infarction, increased troponin level and SPT changes on ECG. Heart failure and myocarditis is another type of the presentation, because myocarditis is never been extensively evaluated, because we know that we don't want to utilize the cardiac MRI in these type of patients. We don't want to contaminate the MRI room. So MRI are less often done in myocarditis cases. So these myocarditis, and then the biopsy is not recommended. So the extensive evaluation of the myocarditis is still not been done. But myocarditis is suspected in a patient when patient present with the acute onset chest pain, and when you see that there is a diffuse STT changes. A patient presenting with a cardiac arrhythmia or hemodynamic instability, you should suspect that patient has developed myocarditis. If you see that there is a LV dilatation, or there is a regional warm motion abnormality in more than 2 or 3 territory, then you suspect there is an associated myocarditis. Another indicator is the significant jump into the cardiac troponin or BNP or pro-BNP levels from the baseline, and or acute heart failure, acute cardiogenic shock. These all indicate the patient might have developed acute myocarditis. So in these type of patient, since MR if available, should be done, but it is most often not done because of the cardiac MRI. Cardiac CT should be, coronary CT should be, can be done in a patient who had a risk factor and to rule out coronary disease. Cardiogenic shock, how will you manage the cardiogenic shock? As we diagnose the cardiogenic shock as any other patient of cardiogenic shock, and we manage the patient of cardiogenic shock as in any other patient. We categorize the patient dry or wet or warm or cold, and then we manage with the fluid therapy or with the inotrope or a combination of that. So cardiogenic shock, if patient with having a extensive anterior wall MI, or there is a acute decompensated heart failure, one must suspect there is a cardiogenic shock. And initial approach with the cardiogenic shock when the COVID status is unknown, we should be having a full protection with the PPN, manage the cardiogenic shock. If the cardiogenic shock is confirmed and there is a COVID status is then evaluated, and the COVID status depend if there is a cardiogenic shock is not confirmed, then we should be suspecting that this patient is having a COVID infection which is leading to the shock. Arrhythmia, as we know that any other cardiac condition, the patient may present with the tachyarrhythmia or bradyarrhythmia. The supraventricular tachycardia, AF or ventricular arrhythmias are common. Channelopathy can precipitate arrhythmias in these type of situations. Bradyarrhythmia, AV block, and sinus node dysfunction are also seen. So incidence of arrhythmia is almost 16.7% in total hospitalization is patients in one of the series, and it is as high as 44% in patients who are admitted in the ICU settings. So almost 6% of the patients develop ventricular tachycardia or ventricular fibrillation, and they have higher incidence in patients who had elevated troponin. Sudden death is quite common in COVID-19 infection. It could be because of the silent hypoxia, which may lead to the pulseless electrical activity, and hypoxic respiratory failure. There is a demand ischemia that can also lead to this pulseless electric activity. Pulmonary embolism is an important cause of sudden cardiac death in COVID infection because of the increased thrombogenicity. Cardiogenic shock with the pulseless electric activity in the multi-organ failure is the it's almost end of the disease, and the myocarditis or cytokine storm can also lead to the sudden cardiac death. Arrhythmia in COVID-19 infection, especially the torsade, because of the drug therapy, because of the pre-existing long QT syndrome, they can precipitate the sudden death. And ventricular fibrillation in the COVID infection with the cardiac involvement is a common condition. When the patient presents with the cardiogenic shock or with the heart failure, that the ventricular fibrillation is important cause. And then the primary arrhythmia syndrome, which can be exacerbated with the COVID-19 infections. For example, the channelopathy can be exacerbated with the COVID-19 infection, and that can cause a sudden cardiac death. That also important to note that the arrhythmias which should be seen in an early phase and should be managed because of the COVID fears, there is a less chances of patients seeking consultation and admission. So myocardial infarction with delay care, and then the patient developing ischemic ventricular fibrillation at home. This is a common condition. And then there is a delay of seeking the patient of arrhythmia in the COVID era, and then the less chances of patient getting ICD or any other ablation therapy. Thromboembolism is a very important cause, and it is very common in severe COVID infection. It has been seen that deep vein thrombosis is present in almost 70 to 100% of the COVID-19 patient who had not survived, and the venous thromboembolism is seen in the almost 20 to 35% of the patient in the ICU setting. Arterial thrombosis is also important, and it can result into the myocardial infarction or a stroke, and up to 4% of hospitalized COVID infection in the ICU has been reported to be having this arterial thrombosis. you can see that I can see this slide, and you can see that during my any thrombotic complication, one important complication was that this patient was having thrombus in the aorta without any risk factor. That patient develops thrombus within the aorta. You can see this globular hypoechoic shadow in the radiolucent shadow within the thrombus, and that causes that thrombus caused the splenic infarct. Fortunately, this patient had thrombus in the descending aorta, not in the ascending aorta. Otherwise, this patient could have developed a massive stroke. This patient, without any risk factor, and she was quite mobile and developed deep vein thrombosis. So, pulmonary embolism is important catastrophic complication in COVID-19 infection, and it should be suspected when there is a sudden worsening of the respiratory worsening and without any significant change in the chest X-ray. And when there is a patient, as we know that there is a hypoxia, tachycardia, or tachypnea, all these are the manifestation, all these are the markers of the pulmonary embolism. One should suspect when patient present with the tachypnea, tachycardia, or hypotension, one should suspect the pulmonary embolism. New onset ECG changes, especially S1Q2, Q3, T3 syndrome, or new onset right ventral branch block, or RV strain are very suggestive of the pulmonary embolism. One should suspect that there is a chances of pulmonary embolism. And when patient is having deep vein thrombosis, one must be very careful about the onset of this deadly complication. Another important aspect of COVID infection is that there is a diffuse microvascular thrombosis. Clots are seen all over the small vessel of the lungs, heart, and as liver, and as well as the kidneys. And the anticoagulation therapy should be initiated in every patient of the COVID-19, especially the moderate to severe degree of the COVID-19 infection, until unless there is a contraindications. So coming to the diagnosis, I will just restrict my presentation to the use of cardiac diagnostic tools. So we are non-invasive testing. What we use is ECG, echocardiography, cardiac CT, and nuclear study, cardiac MRI, and exercise testing. So how should we utilize these services in this COVID era? Obviously, ECG should be done into each and every patient, and especially we should look for the changes or the QT interval, new onset STT changes, and look for the arrhythmias. And ECG should be done in each patient. And in moderate to severe category, it should be repeated daily or alternate day, and as and when required. Echocardiography, it should be avoided because in the dedicated echocardiography room, patient should not be shifted. If you are going to do with the point of care devices, or use the ultrasound machine with the focus acquisition of the images and the focus analysis of the echocardiography. You just have to look for the LV contractility, RV contractility. If you can measure, you can use the measure the TAPSE, and then you can use the hepatic vein or IVC dimension. Transesophageal echocardiography should be avoided because it generates aerosol and it causes increased chances of infection. TE should be avoided. If there is no alternative imaging modalities available, then TE should be considered. Otherwise, TE should be avoided by any cost. Cardiac CT is a very important tool, and it should be used in when the TE is indicated, and then it has a very important tool in the cardiovascular disease management. Indication is when there is you suspect any coronary artery disease in a patient, then cardiac CT should be done instead of exercise testing or SPECT testing. Acute symptomatic valve dysfunction, cardiac CT can be used. Left ventricular assist device dysfunction, cardiac CT can be used. And importantly, when you are suspecting pulmonary embolism, cardiac CT should be considered as early as possible. And when you are planning, which is unlikely, is urgent structural intervention, you planning tower, etc., then cardiac CT can be used. And then you can use to rule out presence of the intracardiac thrombosis. Nuclear cardiology, as we already discussed, the SPECT or PET should not be used for the diagnosis of ischemia, and PET CT is usually should be done only for the diagnosis of endocarditis in the prosthetic valves or intracardiac devices, because in these situations the transthoracic echocardiography is a little difficult to detect the endocarditis. Cardiac MRI is important tool, but remember that you have to shift to the cardiac MRI, and then you have to take all the precaution of the IPC. Exercise testing is also restricted. It should not be done in general in the COVID era. And then you should be restricted. This exercise testing is restricted when the patient when in a heart transplant program, and for the diagnosis of the heart failure when you are suspecting there is a diastolic dysfunction. Invasive testing, invasive cardiac angiography, coronary angiography should be done when you are planning to do primary angioplasty, or in a patient with a very high risk of ST elevation, non-ST elevation MI, where you are planning to do the revascularization. Already discussed that TE should not be done. Endomyocardial biopsy is not recommended at this moment of the time. Management regarding the COVID specific and general management, I will just go through because we have to cover this. Obviously, the Ministry of Health and Family Welfare has given us as the guideline how to manage the mild, moderate, and severe category of the patients. We must follow that, and we must remember what is the side effects of these drugs, which has been recommended by Ministry of Health and Family Welfare. Remdesivir is very safe for the cardiac, from the cardiac point of view. You should remember that what are the indication, what are the contraindications. Similarly, the convalescent plasma is also safe from the cardiac point of view. We should use, but remember that transfusion related adverse events can occur. Then we have to be very careful about that. Tocilizumab is indication. There is no specific cardiac contraindication, or there is no specific cardiac side effects because of these drugs, but one should rule out infection, active infection, because in this when we are going to use this drug. Recently, 2 more drugs have been approved by the DCGI, and these drugs are also very safe from the cardiac point of view. This steroid used in the COVID-19 is very important. And we know that in the moderate to severe pneumonia, this meta-analysis has given a very good insight about the use of the steroid in the patient of moderate to severe disease. It has shown that the use of, I'm sorry for the change in the box, but you must remember that the overall the dexamethasone has more than 60% reduction in the mortality. And similarly, the methyl prednisolone has shown there is almost 30% reduction in the cardiac mortality. So this is dexamethasone and methyl prednisolone are very important tool to prevent mortality in the COVID-19 patients. Pulse methyl prednisolone is upcoming therapy, and it is especially useful when we are suspecting the cytokine is strong. And it can be tried in the worsening dyspnea. And it is very important when there is a severe COVID pneumonia and when there is a resolving pneumonia or organizing pneumonia, which also affect the right ventricle. So this is a very important drug. Management of hypoxia, we know that we start with the face mask or the nasal prong. Nasal prong should be preferred. If the patient is not maintaining the saturation more than 94%, then we'll go to the non-breathable face mask, and then if it is still not maintaining the saturation, then we go for the high frequency nasal cannula. Now, high frequency nasal cannula is very important tool because it gives a small amount of PEEP to the patient, peak and expiratory pressure 5 to 6 millimeter mercury, and it can deliver up to 100% of the oxygen to the patients. And then what is the role of the NIV? NIV should not be used when you are trying to use with the standalone devices. It should be used with the inbuilt, which is inbuilt in the ventilator with the two-limbed circuit, because we don't want to have expired air in the ICU, because it has to be two-limbed circuit and with the filter. And then it should be used in the patient when the patient HFNC is not available, or when patient is not maintaining oxygen saturation on HFNC. Then NIV can be used, and failure of NIV should be suspected when there is a worsening sensorium, there is a increased respiratory muscle effort, there is a raising pulmonary PCO2. PCO2 is rising. It means that patient is not having enough efforts, or there is a worsening pH which is related to the PCO2. Mechanical ventilator, obviously we indication is when the PO2 and FiO2 ratio is less than 200, and there is a marked respiratory distress and patient is in the shock. These are three important indications. We start with the full volume control or pressure control, and the tidal volume is almost 6 to 8 with the ideal body weight. And then we start with the peak of 8, and then we can go up to the 18, and try to maintain the saturation 90 to 92%, not up to the 100%. And we try to maintain this saturation with the lowest possible oxygen saturation. Prone ventilation is also very important. Should be used in the moderate case, and when we know that the patient, it should be used in the non-intubated patient, and we should be careful that the oxygen supply to the patient, oxygen therapy to the patient should not be hampered in the prone ventilation. So basically, the patient who is having oxygen requirement more than 4 liters, having normal mental status and able to self-prone or manage with some little efforts, then these patients should be encouraged to do the prone ventilation. And these ventilation is 30 to 120 minutes, and then patient asked to left lateral position, the right lateral position, then supine position. And that you should be careful about the hemodynamic stability during this prone ventilation. Close monitoring should be done. Anticoagulation is very important aspect for the prevention of the cardiovascular outcome. This low molecular weight heparin should be given to each and every patient of the moderate to severe intensity. And initially should be, if patient is having moderate intensity, if there is no evidence of thrombosis or evidence of any hypercoagulability state, the 40 milligrams of subcutaneous enoxaparin should be given in the prophylactic dose. And the therapeutic dose is twice daily doses. Which can range from the 0.5 to 1 milligram per kg body weight. Another alternative is the fondaparinux, unfractionated heparin. And contraindication, obviously, when the patient is having high bleeding risk or low platelet count, or the patient is having ESRD, then the low molecular weight heparin should not be used. A patient is already taking NOACs, then these patients should be encouraged to continue with the NOAC, because NOACs are preferred and because we don't have to monitor and they have a good efficacy. And if patient is having difficulty in swallowing, then we can crush the tablet and we can give with the RISU. So in the patient who is having a normal creatine clearance, if you using a standard dose is almost 40 milligram per day. If intermediate intensity is 0.5 milligram per kg 12-hourly, and the therapeutic intensity is 1 milligram 12-hourly. Similarly, if the patient is using lower serum creatine clearance, then one should be using unfractionated heparin in the dose of 5,000 to 7,500 from OD dose to 8-hourly doses. This is important slide because we often neglect this aspect of considering anticoagulation at the discharge, and because we know that the COVID-19 is a hypercoagulable state which is going to persist for some times, and then this discharge anticoagulation therapy at discharge should be encouraged. Patients who are having prophylactic anticoagulation should be given anticoagulation, because we don't have betrixaban in our India. We can use rivaroxaban 10 milligram daily for 30 to 40 days, or otherwise we can use enoxaparin 40 milligram daily for 28 days. And patient who developed any complication of thrombosis in any form, they should be treated as something like patient of developing patient of venous thromboembolism, that means the anticoagulation should be continued for at least 3 months. For hypotension, the therapy is similar. First step is you have to resuscitate the fluid animal per se over 3 hours. But remember, in the patient of ARDS, we have to be very careful about the fluid therapy. And the second step, you have to use the NORAD in the septic dose. The third step, if the mean arterial pressure is non-pretending more than 65, then you add medicine. The fourth step, then after that, you increase the dose of NORAD. And then if it is still not maintaining, then you start hydrocortisone infusion in place of the dexamethasone. And then if the patient is if it is maintaining the mean arterial pressure, then try to taper the NORAD first. If it comes to almost less than 1 ml, then stop vasopressin and continue with the NORAD. CVD management, specific management, obviously there is a urgency in the emergency category of the patient. The patient of estelivation MI or non-estelivation MI, cardiogenic shock, these are emergency patients should be taken to the Cath lab. According to this is the guideline of the European Academy of the Cardiopulmonary. This are the European guidelines, and then the guidelines for the ESC. All guidelines have shown that the very high risk or high risk should be taken to the invasive therapy, and the high risk. These are the guidelines from the estelivation MI, and these are guidelines of the non-estelivation MI. High risk patients should be taken to the Cath lab. Remember that Cath lab, taking patient to the Cath lab has a different ball game, because we have to have dedicated COVID Cath lab where all the staff should be wearing PPE. There should be separate ventilation system. There should be separate CPR modalities, and then the intubation threshold should be very low in these patients with the borderline respiratory status. Because of this, so there is a resurgence of the thrombolytic therapy, because we know that the PCI is superior. All the guidelines have shown that in the COVID era, PCI should be preferred. The PCI is superior. It decreases the all-cause mortality. It decreases the rate of reinfarction. It decreases the rate of stroke, because almost 1% develop intracranial hemorrhage in the patient who got thrombolysis. And then if the thrombolysis fails, the patient also, in the failed thrombolysis, you have to go for the PCI. So, and we know that the almost 50% of the patient don't reperfuse, especially when we are using streptokinase. So thrombolytic won't be solving the problem. That is the basis of these guidelines. But remember, because of we have to limit the exposure to the Cath team, because these Cath team is very important person, because they are doing much more important work, such as a pericardiocentesis, putting Swan gas, etc. Putting the ECMO is available, then they should be using ECMO, etc. So they should be exposed least in these situations. But remember that if the thrombolysis fails, then patient can still go to the rescue thrombolysis, rescue PCI. And in the pharmaco-invasive therapy is a known, it is a good track record. It has a proven efficacy. In the pre-COVID era, we know that the 50 to 60% of estelivation MI in India is getting thrombolysis alone. And then in the patient developing estelivation, some of the patient may not be because of the epicardial thrombotic artery. We have seen several case reports, several series of the case reports that patient developing estelivation myocardial infarction, when we see in the coronary angiography, they had a clean artery. It was because of the thrombosis of the microvasculature. It could be because of the thrombosis which got reperfused or which got resolved in due course of the time. So guidance from the SCAI, Society of Cardiovascular Angiography Intervention, and American College of Cardiology, that we have to balance of exposure and patient benefit. Exposure to the Cath lab staff and the patient benefits. And fibrinolysis can be considered to the stable estelivation MI, and patient with active COVID-19 or of suspected COVID-19, you have to use full PPE, including N95 mask, when you are taking this patient to the Cath lab. In the non-escalation MI patients, basically, Cath, the utility of Cath is that it facilitates early discharge, and the considered therapy may be sufficient to many number of the patient, especially the patient who had type 2 myocardial infarction because of the demand and supply mismatch. Cardiogenic shock, we have to manage similar to that patient, and each and every patient of the cardiogenic shock should be taken as a patient of suspected COVID-19 infection, and we should be wearing all types, we should be taking all types of the protection, including the using the PPE. And in the patient who are COVID-19 positive, the mechanical circulatory support system should be very restricted, and if you are using, then use ECMO. Management of tachyarrhythmia, obviously, in the patient who develop atrial fibrillation on flutter, we have to, without hemodynamic instability, we should be using the rate control method. If the patient is hemodynamic unstable, very unstable, then you go to the cardioversion. Otherwise, you can use IV amiodarone as an antiarrhythmic drugs. And the Torsade is common in the ICU setting. Then we have to use the QT prolonging drug. We have to withdraw the QT prolonging drug, maintain the potassium more than 4.5, supplement the magnesium, and increase the heart rate by withdrawing the drug which are causing the rate reduction in the heart rate, or we can use the isoproterenol, or we can use the temporary pacing for that time. And post recovery, the cause of atrial fibrillation flutter could be because of it can be precipitated by because of the COVID infection. So the assessment should be done whether we have to maintain the rate control method or we can go with the rhythm control method. For the bradycardia, obviously we have to avoid the offending drugs, and then in case if we want to increase the heart rate, we can use temporary pacemaker, or we can increase the rate with the use of the atropine or isoproterenol. And after the recovery, we have to reassess is there any need for permanent pacemaker, or it is just because of the temporary caused by the COVID infection. Thromboembolism, obviously, prophylactic anticoagulation is recommended for all the patient of COVID-19 infection. And when you suspect any patient of pulmonary embolism, we should be using the latest guideline of ESC, that patient in shock or patient having RV dysfunction should immediately receive reperfusion therapy in the form of the thrombolytic therapy, or hemodynamically stable patient should receive unfractured heparin, low molecular heparin, or NOACs in form of any rivaroxaban or any other drugs as an oral treatment. There is a lots of controversy regarding the use of the ACE inhibitor or ARB. All this is very congested slide, but I have to enumerate all the guidelines. All the guidelines have recommended the ACE inhibitor or ARB. There is no need to stop ACE inhibitor or ARB. So with this, I will just end, and I will just conclude with my presentation that cardiovascular complications, either naive or exacerbation caused by the COVID infection, or is a major chunk of they cause a major chunk of the mortality in these type of COVID-19 infections. The timely detection and prompt intervention is of utmost importance in this era to curtail the health burden incurred by the current pandemic. Thank you very much for your kind attention.